I am Dr. Keith Kowalczyk. I am a urologic oncologist at MedStar, Georgetown University Hospital. My patients are cancer patients that have malignancies or cancers of the genitourinary system, so that's anything from prostate cancer to kidney cancer to bladder cancer to even adrenal cancer. So anyone with those conditions I will treat. What's exciting about my job is my patients. I love my patients. I love going in, and I love, especially now having been practiced for over 10 years, I know my patients very personally, and I enjoy meeting them and meeting with their families and seeing how they're doing. So that gets me through long days very easily, as it doesn't feel like a job to me. I'm just meeting a bunch of my friends for the day and seeing how they're doing and hoping I can get them through whatever next steps we need to get through, or just catch up and say hello. What we deal with can sometimes be somewhat embarrassing for the patient. So it's nice to have and be able to have a good sense of humor and bring the patients through that with a good sense of humor. And I find that urology brings all of that together, treating patients in the beginning, operating on them, curing them, and then following them for a lifetime, and then even seeing their family members, and all at the same time being a friend to them, helping them laugh and get through it, and that's been very rewarding to me. Urology is always cutting edge, so that's what gets me excited about urology. We are always looking at the next best thing, and we are always on the forefront of technology, which is another reason why I wanted to go into the field. When I first started as a student is when we were first getting involved with robotic surgery, and now that's become commonplace. And we're pushing the limits of what we can do with robotic surgery every year. Surgeries that, when I first started practice, we were doing open, and we are now doing robotically, which gets patients out of the hospital in just a matter of days rather than a couple of weeks. And that's all because of robotic technology, and that improves every year, and that's very exciting. But we're also moving past that. We're trying to look past just surgical options to minimally invasive options where we don't have to remove the organs, where we can do what's called focal therapy, or just treat part of the organs, and part of that is having better imaging or better studies so we can see where tumors are and what needs to be treated and what doesn't. So, quality of life in urology is very, very big, and we're using technology to make our treatments much easier on patients and letting them live a long time, not just free of cancer, but also with a great quality of life. Patients with urologic cancers should come to MedStar Georgetown because it isn't just me who is going to direct your care. I am part of a team of wonderful people. I'm the urologist, and we tend to be the quarterbacks for urologic cancers, but I work with amazing medical oncologists. I work with amazing radiation oncologists. We have some of the best radiologists in the world who can help me look at your CT scans and MRIs. And we meet every 2 weeks to go over cases to see what is the best approach for your cancer in your individual case. So it's never a one-size-fits-all for us. We all meet together to figure out what is the best treatment option for you. So urologic cancers are any cancer or malignancy or uncontrolled cell growth in the urologic organs. And going from the top down, that involves your adrenal glands, your kidney, the lining of the kidney, which is called the renal pelvis or urothelium, the lining of the ureter, which is the tube that connects the kidney to the bladder itself, the prostate, which is underneath the bladder, which is only in men, the urethra, and the penis and the testicles. Prostate cancer is the most common cause of cancer death in men in the United States, and the second most commonly diagnosed cancer in men in the United States. So it's unbelievably common. It is so common that most men in their lifetime will likely develop prostate cancer. The question that we have to answer as urologic oncologists are which of these cancers need to be aggressively treated and when, and which of these cancers can be let go and watched. Now, we discover prostate cancer in generally much earlier now than we used to 30 years ago, and that's because of PSA screening. PSA is a blood test that we use to check for prostate cancer. There are not many screening tests like that for multiple other cancers, and because of that, we find these cancers very early, and the mortality or death from prostate cancer has dropped significantly since the 90s because of PSA screening. At the same time, that means that we catch these cancers very, very early, and we may actually catch some cancers when they don't need to be caught. In other words, there may be some of these cancers that will never have an impact on a patient's life, and they can live years and years and years without having to worry about prostate cancer. So we want to avoid over-treating those patients, but it is still the second leading cause of cancer death in men. So it still cannot be ignored, and we have to figure out which patients cannot be watched and which patients need aggressive treatment right now rather than waiting. And that's the challenge for me as a urologic oncologist that specializes in prostate cancer, and really anyone across the country, is helping a patient navigate that. Number one, do you have cancer that needs to be treated at all? And number two, if you do, how are we going to treat it? We know that certain risk factors of prostate cancer tend to be familial. So if you have a family history of prostate cancer, you're at higher risk of having prostate cancer. In addition, it tends to be race-based. Black men are at higher risk of having prostate cancer. So there is something in the genes that are passed down in these families that are leading to increased risks. And we don't really have the exact answer why on that. We have found some mutations, such as BRCA, that lead to increased risk for prostate cancer. So we're getting better at finding these risk factors and why. Smoking may have a slightly increased risk for prostate cancer, but not so much as a bladder cancer or lung cancer or other cancers that you hear about. In addition, obesity may lead to increased risks of higher risk prostate cancer. So not necessarily increased rates of prostate cancer, but obese men, when they get prostate cancer, it tends to be more aggressive, and that may be because of hormonal changes. Prostate cancer is very dependent on hormones like testosterone, and estrogen can affect it as well. Obese men tend to have changes in these hormones that could affect the tumor. So prostate cancer is diagnosed generally by the blood test PSA, which stands for prostate-specific antigen, in which we recommend men that have a higher risk of prostate cancer get checked every year, and that would be men with a family history and their father or brother, or African American or black men. Because we find it by a blood test, there are generally no symptoms from prostate cancer. So one of the questions I get asked all the time by patients is, well, I didn't feel anything. You know, I feel fine, but that's what we want. We want to catch these cancers by a blood test rather than by symptoms. So prostate cancer is diagnosed most of the time by PSA and not by symptoms. Once we get the biopsy result, we will get a lot of information that we'll have to digest together. And that will include how aggressive is the cancer, how much of the cancer is there, does this need to be treated now, or can this wait to be treated? If we decide that this is a cancer that needs to be treated next, we'll go through all of the options. The best option in general, and there's no black or white here, there's a lot of gray, but in general, for younger men that are healthy, the best option tends to be prostatectomy, removal of the entire prostate. That gives us the best long-term cancer-free recurrence rates, and that's why we tend to want to do that for our younger patients who have a very long life expectancy. Other options include radiation options, and that can include CyberKnife, that can include brachytherapy, which is prostate seeds, that can include the traditional radiation, IMRT, but in general radiation therapies, and that's why I'll call on my colleagues with radiation oncology to discuss those options as well. If the cancer isn't quite lowest risk, but it's not high risk, and somewhere in between. In some men, we may consider the more experimental type treatments, which are focal therapies, where we only treat part of the prostate. We don't remove the whole prostate or radiate the whole prostate, but we can treat that one part of the prostate that seems to be the problem area by either freezing the prostate or heating that area of the prostate up with microwave beams, essentially. So we do all of this at MedStar Georgetown, and each cancer is different, each patient is different, and we'll discuss all of those options to see what's best for you. Our experience has been that Retzius-sparing prostatectomy is just as effective at curing prostate cancer as standard prostatectomy, while also leading to increased overall quality of life, as well as much lower chance of having urinary incontinence. Men at risk for prostate cancer are Black or African American men. They have about a 1 in 6 chance of developing prostate cancer in their lifetime. Also, men with a primary relative that has prostate cancer, so that's a father or a brother, are at increased risk of having prostate cancer. Along those lines, we have noticed that there are genetic mutations that are handed down through families that can increase one's risk for prostate cancer. And one of the newest and most common is the BRCA gene, which we commonly associate with ovarian and breast cancer. And we're actually finding that men in those families are at increased risk of prostate cancer as well. So these are the patients that we really need to focus our screening on, and screen these patients every year and very carefully. And these are the patients that should not be left to semi-annual, every 3-year screening. We need to screen these patients every year. If someone is having symptoms from prostate cancer, unfortunately, it's generally an advanced prostate cancer. So the prostate is an organ that sits underneath the bladder. So one of the first symptoms that one might have is blood in the urine or difficulty going to the bathroom. Another symptom is if the cancer has spread. And generally when prostate cancer spreads, it goes to the lower back. So some men will have lower back pain. Another symptom may be swelling in the legs for some men, and that's because prostate cancer tends to spread to the lymph nodes in the pelvis, which the lymph nodes are little cleaning pods, I like to say, that run along with blood vessels to clean them of any infections or inflammation that they may have. Cancer also tends to spread via the lymph nodes, and they can get very enlarged and therefore block the blood vessels coming up from the legs, and men can get leg swelling from that. So it could be blood in the urine, difficulty with urination, back pain, leg swelling. But again, these are generally symptoms of well-advanced prostate cancer. And thankfully, because of PSA, we don't see that as often anymore. Something that is frequently said, and that is true, is that most men in their life will get prostate cancer. That's not a question. The question is it going to be a prostate cancer that is going to affect you in your life? So it is a natural part of aging, and it happens in most men. But the key is to find the cells that will become lethal to you, and that's finding it earlier on in life. Most PSAs in America are checked by primary care physicians. So that is the place to start if you want to get your PSA checked. If you have any other further questions, or if there's any question about your PSA potentially being a little bit higher than you think it should be, go and get a second opinion from a urologist. We won't necessarily take you right to get a biopsy that day and then operate on your prostate the next day. That's not what we do anymore. Our job is to, number one, see if you even need a biopsy, and then if you do get a biopsy that's positive, to give you all of the options, one of which could include active surveillance, not doing anything right now until it gets worse. Primarily, you should seek getting your PSA checked by your primary care doctor, or at least ask them about it. If you have further questions about it, then come to a urologist. Some primary care physicians will check a PSA automatically every year, and some won't, because PSA screening is not meant for every man every year. However, If you are at higher risk of prostate cancer, if you have a family history, if you are Black, if you have a history of ovarian or breast cancer, which could imply that you have a BRCA mutation, you should seriously ask your primary care doctor about getting a PSA. At least have that discussion. If you want further discussion with it, then come to a urologist, and we'll talk to you more about the pros and cons of PSA screening. We recommend that all men between 55 and 70 have a frank discussion with their primary care physician or urologist about PSA screening, because that is the age at highest risk of having prostate cancer. If you yourself are at high risk of having prostate cancer, so you have a family history, African American, BRCA2 mutation in your family, you should be screened, and you should be given that option. And if you're not, then you should seek a second opinion. If you don't have any of those risk factors, it may not be necessary, but having one PSA checked can't hurt. If there's any question about that PSA being high, then go see a urologist, and you don't necessarily need a biopsy. But there are plenty of men without those risk factors that get serious prostate cancer. So that's why I would recommend that all men get at least one PSA checked in their life. An elevated PSA does not necessarily mean that you have prostate cancer. It is just a red flag that we should look into this further. It stands for prostate-specific antigen, but is not prostate cancer specific. So if a man has an enlarged prostate, they'll tend to have a higher PSA. Older men tend to have higher PSAs. So when the PSA reaches above a certain amount, or it looks like it's rising from what it used to be, they'll generally get sent to us or another urologist to look into that further. The first thing I do is to recheck the PSA, because it may be a false positive. The second thing I do is look at the trend of the PSA. Has it been going up at a steady pace? Has it been going up very sharply? If I'm suspicious at all, we can get further tests at that point. Some of these tests aren't for all patients, but we can get specialized PSA tests like a 4K score. We can get urinary tests that can actually look for shedded cancer DNA products in the urine. And what I think is one of our strongest diagnostic tools in prostate cancer right now is getting an MRI of the prostate. And that's a very specialized MRI that very few centers do, and we at Georgetown have been doing for over 10 years now. An MRI can pick up very high-risk prostate cancers, the ones that we want to find and we want to treat aggressively. If an MRI is negative, that doesn't mean that prostate cancer isn't there, but it may be one of the slower-growing prostate cancers that we don't necessarily have to treat. So if you have an elevated PSA, I'll probably work that up with an MRI afterwards. If the MRI is negative, we may still have to proceed to the next step. If it's positive, we'll definitely proceed to the next step. If we've decided that the next best step is to do a prostate biopsy to get that diagnosis of prostate cancer, patients can be assured that at MedStar Georgetown University Hospital, you are going to get the newest technology with the best results of the biopsy and the fewest complications. And that's because 2 years ago, we introduced a newer form of biopsy that we can do in the office called a transperineal prostate biopsy. So this has reduced the risk of infections almost to 0%, which was a problem with the old types of biopsies or other types of biopsies, and also increased our diagnostic yield. We actually noticed that we can sample a lot more of the prostate this way than we could with the way we used to do the biopsies. In addition, with the MRIs that we get at Georgetown, we can use those to pinpoint where we want to focus our biopsies to make sure that the patient gets an accurate diagnosis. One of the most common questions I get is, what is a normal PSA? If I'm taking a test or I need to give you an answer or what's on that, the lab form will say that a normal PSA should be less than 4, but it is not that easy. Patients at different ages have different PSA levels, so all of that comes into play. When someone comes in with a PSA level to me, all that matters to me is how old you are and what were your past PSAs, and not necessarily a total PSA level. Because a PSA of 2 may be considered normal in an older man who's in his 60s. A PSA of 2 in a man in his 40s is not normal. But if we use that cutoff of a 4, then we would be missing a potential prostate cancer in that young patient. So the normal PSA is individualized for each patient based on how old they are, also how big their prostate is, and also if they have any other symptoms. If they're having burning with urination, it could be a false elevation because of an infection. So for me, it's more the trend in your PSA and if that trend changes. So each person in general will have their own baseline PSA that I will follow over time. Now there are some PSAs that are very worrisome. Any PSA over 10 is certainly worrisome. But when you get to saying that a normal PSA is below 4 and above 4, it's much more nuanced than that. Annual PSA screening is not for everybody. However, I do advocate that every man gets at least one PSA checked in their lifetime. Now, PSA screening for every single man every year is probably too much because there are a lot of men that will not be at high risk for cancer, and they may get a diagnosis of a very low risk cancer, and that may lead to a very aggressive treatment that's not needed. So that's why I say it's not for everybody. However, for high risk men, Black men, men with a family history of prostate cancer, men that have the BRCA2 gene, they need to be screened every year. So the general recommendations of the American Urologic Association are that all men at least have a discussion with their primary care physician or urologist about PSA screening, the pros and cons, whether they should get it between ages 50 and 70. That's for the general population. Again, for men at risk, Black men, men with a family history, men with BRCA2 gene, they should be screened every year in that age group from 55 to 70, probably even earlier. We would advocate that those men get checked starting in their 40s, either age 40 to 45, depending on which guidelines you follow. I also advocate what's called the baseline PSA, and that's what I recommend every man should get in his 40s. Some men may get aggressive prostate cancers without any of these risk factors, and we see that unfortunately all too often. And just checking one PSA in their 40s may have prevented that. So what's called the baseline PSA is just checking a single PSA level in all men in their 40s. If that PSA is over 1 to 1.2, they're considered a higher risk, and those are patients that I check every year. I put them in the same group as all the other men with high-risk prostate cancer, and I check every year. If that PSA is less than 1 and they don't have any other risk factors, they don't have to worry about PSA screening every year until they're 55. And then when they reach that age from 55 to 70, when prostate cancer is most common, they can get it checked every year to 2 to 3 years, but it does not have to be done every year. So the key to prostate cancer screening is not, let's not screen anybody. It's not, let's screen everybody. It's, let's screen the people that are at high risk and do it selectively and do it intelligently. If I get a patient that has a family history of BRCA2 gene, we will send them to our excellent genetic counselors at Lombardi Cancer Center, who will then do a full profile, genetic risk profile. And if they come back with the BRCA2 mutation, that's when we'll start screening them very thoroughly. PSA is the main intro screening test, which leads to a red flag to maybe get what I call second-level PSA testing. And that can include blood tests that add on to the PSA that is more specific for prostate cancer, less specific for, say, enlarged prostate or prostate inflammation. And that can include a 4K score, a PHI or prostate health index. That can include a urinary test that detects DNA, tumor DNA in the urine called an exosome DX. So in some patients where I'm on the fence whether we should proceed with getting a biopsy or not, those are the type of tests that I would get. And I would also consider getting an MRI in those patients. If we catch prostate cancer early, the prognosis is excellent, which is why screening with PSA in high-risk patients is so important. If we catch a prostate cancer that's still within the prostate, whether they choose to have surgery, radiation, the cure rate is over 99% for 10 years, as long as we find it early. Treatment depends on, number one, the patient's wishes, and number two, how aggressive the cancer is. There are multiple different variables that go into deciding first whether a cancer needs to be treated. And if a cancer is very high risk, we'll be very, very aggressive, especially if the patient is very young. If it's low risk, then we'll tend to be not so aggressive and potentially just observe that cancer. And if it starts to grow, we can treat at that time. All of these treatments will have some impact on quality of life. So you have to discuss all of those with your patients and let them know what to expect after each and every treatment. And as long as it is safe, as long as I feel that that treatment is going to treat your cancer adequately, I will then tell you what are the pros and cons of each of those appropriate treatments. And then from there, it's the patient's choice. So I'll present all of the options. I'll tell them the ones that I don't think is appropriate for their cancer if it's too aggressive. I'll tell them the treatment options I think is most appropriate. And then of those options, I'll go over the pros and cons and what to expect within the first year, after the second year. What are the chances of the cancer coming back? And we make an informed decision together, and that's how we decide how you're going to be treated. Robotic surgery is an extension of laparoscopic surgery. So laparoscopic surgery is what we call keyhole surgery. Small incisions through which little ports or little holes are placed through, and we can do a big surgery on the inside of the body with small instruments and small incisions. That tends to lead to less blood loss, much earlier recovery. However, traditional laparoscopic instruments are not as facile as our hands. It's difficult to do intricate surgeries, and when we do surgeries as urologists, it tends to be in the pelvis with the prostate and the bladder, or even with the kidney and having to reconstruct the kidney. And that can be too difficult with laparoscopic instruments. What robotic surgery has done is taken the best out of open surgery and applied it to laparoscopic surgery. It's allowed these instruments to mimic the motions of my hands. So it's the best of both worlds. I can go in and do a minimally invasive procedure through small incisions, but I can also do very complex things with the robot in a very small space that I would not be able to do with traditional laparoscopic instruments. This has completely changed the way we treat prostate cancer. The prostate is located deep in the pelvis, underneath the pelvic bones, and it's very difficult to get to. When we remove the prostate, we then have to connect the bladder back to the urethra, which means a lot of suturing. And you can imagine reconnecting pipes and doing that without much vision in the open surgery. Doing that with very rudimentary instruments with laparoscopic surgery was not easy. Robotic surgery changed all of that. We can do these procedures now in under 2 hours, and the patients can go home within 24 hours, and they, for the most part, have no pain, and for the most part, don't need any narcotic pain medicine. So that's where robotics has really helped. We also use robotic surgery. We've advanced what we use robotic surgery on over the years. We do it for very complex kidney cancers. We do it for bladder cancer now. We can remove the bladder and then replace the whole bladder with pieces of intestine, all using the robot. None of this happened 10 years ago, but we're doing all of this at MedStar Georgetown now. The outcomes are patient-centered. So the patient can get back to work sooner. They have less pain, they're in the hospital for a less amount of time, they can get to their families sooner. Where this really helps with oncology and cancer surgeries is that if a patient is not just getting surgery, but they need what we call systemic therapy, like a chemotherapy or immunotherapy after surgery, they're generally recovered very quickly. So we can get them to those therapies much, much sooner when we do minimally invasive surgeries rather than open surgeries. There'll always be a place for open surgery. I still do open surgeries, and it's something that if we need to do it, we'll do it. But if we can do it robotically, we're going to do that because it's going to be better for the patient in the long term. It's called robotic surgery, but the robot is not operating on its own at all. I am in complete control of the robot the entire time. I am telling those robotic arms what to do. It's merely just an extension of my arms, letting me do more through smaller incisions. I am in complete control of the robot the entire time. So while the robot is an excellent tool, it is only as good as the surgeon operating on it. And that's why it's very important to still go to an experienced surgeon. It's not some futuristic, press a button, my surgery is done. The surgeon needs to have done hundreds of these procedures for you to get the best possible outcome. At MedStar Georgetown University Hospital, we have an extremely experienced robotic team. We have been doing hundreds of these procedures over the last 10 years. We have excellent outcomes in not only prostatectomy, but kidney surgeries, partial nephrectomy, radical nephrectomy, even advanced kidney cancer cases where we have to replace parts of blood vessels. We can do that robotically along with my colleagues in hepatobiliary surgery who are also amazing robotic surgeons. So we have some of the best robotic surgeons in the world at MedStar Georgetown University Hospital. Other than robotic prostatectomy as the main gold standard for treatment of prostate cancer, there are some less invasive procedural options for prostate cancer, and that tends to be focal therapy for prostate cancer. MRI has revolutionized the way we diagnose but also now treat prostate cancer, because if we can locate where one tumor is in the prostate, if there are no other tumors, there's a potential that we can either use freezing or high-intensity focused ultrasounds that basically burn the tumor just in that one area and potentially spare the side effects of surgery or radiation. The caveat with that is it is experimental, so it is not for every patient, and there is a possibility that cancer could come back, but we can still treat it again potentially with focal therapy, or we could do surgery or radiation after that. But that is on the horizon. I think will be in the future one of the main treatment options for prostate cancer. At MedStar Georgetown University Hospital, we are one of the only centers in the world to offer a new type of robotic prostatectomy that's called Retzius-sparing robotic prostatectomy. I've been performing the surgery for about 3 years now, and I'm one of the highest volume surgeons to do this surgery in the United States. It originated in Italy, actually, and those are the surgeons that helped me basically become good at this surgery. The reason why it's different from traditional prostatectomy is with traditional prostatectomy, you have to detach the bladder and other ligaments that pull the urethra, which is where we empty our urine out. We have to detach those ligaments from their natural places to get to the prostate. It's easier to do the surgery that way. Instead of going on top of the prostate, I go below the prostate to spare the body's natural ligaments and natural structures that preserve urinary continence. So after I do this procedure, patients get much faster return of their urinary continence and are much less likely to have issues with urinary incontinence after surgery than they would with the standard approach. And we've proven that with our own series that we've published, and we keep on putting out studies of other benefits of this surgery as well. Prostatectomy in general is done for men with cancer that is still confined within the prostate. It is not recommended that men with cancer that has spread beyond the prostate get surgical removal of the prostate or prostatectomy. We are part of a clinical trial that is looking at surgery for men with cancer that has spread outside of the prostate to see if surgery or radiation is applicable to those patients. But outside of that clinical trial, it's not standard of therapy. Like any cancer, prostate cancer can recur after treatment, but here is where PSA comes to help us again. After treatment for prostate cancer, we can use a blood test to see if that cancer has come back. Most cancers we have to use CAT scans to see if the cancer has come back, and only then we know it's come back because we can see it. With prostate cancer, if we see any elevation of the PSA after treatment, we know right away that there is a risk that the cancer has come back. And therefore, we can treat that right away with whatever therapies we may have in that situation. So while there is a risk that prostate cancer can come back, as long as the patient follows up thoroughly, we can get them more treatment to cure the cancer. And that's why overall outcomes and survival for prostate cancer remain excellent. When cancer has come back after radiation, it can be more challenging to treat that. Many of these men will just monitor them to make sure that it doesn't come back and spread. Some of these men may get debilitating hormonal therapies to keep the prostate cancer at bay. Some of these men will get cryotherapy of the prostate, which freezes the entire prostate. However, none of these are curative. It's very rare to offer surgery after radiation because the risks of incontinence as well as the overall risks of the surgery can increase. Recently, with robotic surgery, we've started to offer this option for appropriate men who have recurrence of cancer after radiation. Because of the more precise nature of the surgery, we can avoid injury to the surrounding structures, which was a big problem with open prostatectomy following radiation therapy. Also, we can decrease the risk of bleeding, but now with Retzius-sparing prostatectomy, we can also decrease the risk of incontinence. The risk of incontinence after surgery for prostate cancer that has recurred after radiation was up to 50%. Recent study that we have done has shown that that risk is less than 20% with robotic Retzius-sparing prostatectomy. So these patients have another option now, rather than just hormonal therapy or freezing the prostate, to possibly remove the prostate after the cancer comes back if they've had radiation. Prostate cancer remains the second leading cause of cancer death in men. So it is something to take seriously. It is something that we still need to screen high-risk men for, and we cannot ignore that at all. And that is because if we find the cancer early, the survivorship is excellent. These men will do very, very well, and we can avoid the potential spread of prostate cancer, which even if those men we can treat and have them survive for long periods of time, if they have to be treated with hormonal therapies or radiation therapies, or if they have cancer that's spread to their bones, their quality of life is not very good. And even if they're surviving prostate cancer for a long period of time, that's not just a number. You can't just say they're still alive. Well, they're still alive, but what is their quality of life? So while we talk about all of these survival rates, yeah, the survival rates of prostate cancer are excellent. And if we catch it early, you're going to do very well. There are some men, unfortunately, that we won't catch early, and our choices are limited for those patients. And although we can treat them and help them survive, can we help them survive in a way that they want to? Can we help them survive in a way that they remain comfortable without all of the side effects of the treatments that we're giving them? So yes, prostate cancer overall survival is excellent, but I want quality of life and living with prostate cancer to be excellent. And the only way that we can do that is by finding it early and getting these patients the appropriate treatments.